You're on.
Good afternoon. I think Kevin Price and his team from the Seventh-day Adventist group. Kevin, I think we might have lost your slides. The slides. So can you just?
I'll bring them up again in a moment.
You'll have to do that. Thank you very much. I'd like to again welcome everybody to our 2019 series of webinars for our special interest group of tobacco treatment specialists and smoking cessation specialists. We have quite an interesting year, I believe. It'll be intriguing and it'll be, we hope, stimulating and equally perhaps controversial as well. So for our first speaker this year, I'd like to introduce Anke van der Sterren, whose name I can pronounce because we come from the same background. Not easy to do. It's like saying in Dutch, 88.
That's right.
But Anke's got a really, similar to me, background of being brought up in Australia, hence not much of an accent. Anke, as some of you might know, presented this material, some of this material. She's presented at the APSAD conference late last year in Auckland, and it was so impressive that I thought it would be really worthwhile to show everybody, Australia-wide, nationwide, worldwide, this wonderful work that's going on in the ACT. Anke's worked for a long period of time as a public health researcher, largely in Aboriginal and Torres Strait Islander sectors. Her area of interest has always been sexual health, drug and alcohol, tobacco. Prior to her present position, she was the Alcohol, Tobacco and Other Drug Association project manager for the ACT, and has worked for 5 years at the Centre for Excellence in Indigenous Tobacco Control. What I also do know about Anke is that there are a few awards around Anke's experience. She might have time to tell us about that too. So as you, yes, well, you've got to, in it to win it, and don't be shy. Don't be shy is what I want to say. Anke's going to present on like a complex amount of work. So if you would put up your first slide, Anke, that would be great.
Yeah.
And if we could leave the questions, if you have any, folks, to the end. What's interesting about this, of course, is this collective action, and I think this will be wonderful to hear. Thank you very much, Anke.
Okay, thank you, Renee. Thank you, and hello, everybody. As Renee has said, I work at the Alcohol, Tobacco and Other Drug Association here in the ACT, and I'm the researcher and project manager here. I've been working for several years in tobacco control, including the Aboriginal and Torres Strait Islander sector, but also in the drug and alcohol sector. So I will, how do I advance? It's not advancing for me. Hang on, all right, do it this way. Next. So I'd like to, before I begin, acknowledge the traditional custodians of the lands on which we're all meeting today, the Ngunnawal people here in the ACT, but the custodians of the lands on which you're all sitting today. And I pay my respects to elders, families and ancestors, and acknowledge any Aboriginal and Torres Strait Islander people joining us today. I'd also like to acknowledge, of course, service users of the specialist AOD services here in the ACT who we work with, and particularly those who have nicotine dependence. I'd also like to thank the ACT specialist AOD services who have been involved in our work, the workers, clinicians, executive officers who've all supported the work that we do at ATODA. And also, I'll be explaining later that we work with community pharmacies and on one of our projects. And I'd also like to acknowledge the collaborators and research partners that we've had in some of our activities, and also all the ATODA staff and consultants who are involved in this work. and who have been involved in the past, because this is a culmination of several years. So I'd basically like to talk about, we've been undertaking a number of intense and collaborative tobacco management and smoking cessation activities in the ACT over the past 10 years or so. And I'd like to talk a little bit about these activities and how they've led to shifts in how tobacco management and smoking cessation support is done in drug and alcohol services in the ACT. And specifically, this body of work arose because of a concern around disadvantaged populations in the ACT not having equal access to smoking cessation support. And so I'll be talking a little bit about the context of what's happening in the ACT, some of the activities, the collective activities that we've been doing, and then some examples of how this has led to change and impacted on smoking cessation among service users accessing alcohol and other drug services, and then just making some concluding remarks. I'll be, among other data sources, I'll be referring mainly to three ATODA data sources. One of those is a workforce profile that we did a couple of years ago that had a supplementary tobacco management and smoking cessation section in it. It was a survey administered to staff of alcohol and other drug services in the ACT. And I just want to note that I did want to share this data with you, but the data hasn't been published yet, and so I'd appreciate it if it's not available at this point for citation. There's other data sources that I'm using which have been published are We Can program operational data, which I'll be talking about later, and I'll be explaining what the We Can program is. And also we do a 3-yearly service user satisfaction and outcomes survey, and we have some data from that as well. We did one last year, but the data's not available yet, late last year, but the last data is from 2015. So I'll start by talking a little bit about the context. So the ACT, we're very lucky here that we have the lowest smoking rate in Australia at around 10%. And I think that this is largely due to a number of factors, which include that we're a small jurisdiction that has quite a progressive government that's conducive to collaboration and innovation in tobacco control. We have a higher average education, employment and income, and we also have, of course, benefited from the nationwide policy and regulation, things like taxation and plain packaging policies. But the ACT itself also has a strong record in the regulation of tobacco, so things around sales and advertising, but also, for instance, in 2015, ACT health premises became smoke-free, and a number of alcohol and other drug services are located on ACT health premises or in buildings that they rent from ACT Health, and so are required to be smoke-free. So, however, if we compare to that low smoking rate of 10%, we know that 82% of people accessing alcohol and other drug services in the ACT report being smokers, and that 84% of people who reported being smokers on entry to the Alexander McConaughey Centre, which is our prison here in the ACT. And of course, there's other Australian data which shows high rates of smoking among people experiencing homelessness and people with mental illness. So ACT specialist AOD services, there are 10 specialist AOD services, and 9 of those are non-government organisations, and a number of these provide services to specialist populations. So there are a couple of services for Aboriginal and Torres Strait Islander people. There's a service specifically for women, and also a couple for young people. And then we're the peak body, the Alcohol, Tobacco and Other the Alcohol, Tobacco and Other Drug Association, we're the peak body for those drug and alcohol services. And collectively, these services all provide specialist therapeutic evidence-based treatment interventions that are listed here. And we know from the Service User Satisfaction Survey that we've been able to estimate that between 400 and 500 service users access these specialist services every day. So that's quite a high number. And we know from the surveys that we've done also that people accessing AOD services experience multiple disadvantages. So we have 74% unemployment among service users, and 46% in the survey said they were homeless or at risk of homelessness. We know that this group has multiple intensive and ongoing contacts with these services, depending on the service types, and also are often marginalised and excluded from other health and social settings. So in terms of tobacco control and smoking cessation, drug and alcohol services are a perfect place to access this population because of the high contact that these services have. I'm now just going to describe some of the activities that we've done collectively as a sector around tobacco management and smoking cessation. So just to give a little bit of background to this, 10 to 15 years ago there was not as much being done in tobacco control in the drug and alcohol services, and tobacco was not really strongly embraced as part of the sector's sort of brief, if you like. So the T from ATOD was missing. So smoke-free policies were largely informal and more relaxed, and certainly many services didn't have a written policy. And staff were often, for instance, able to smoke with service users and to take multiple breaks to have smoking breaks. The sector was characterised by high smoking rates among alcohol and other drug workers, and a 2011 survey that ATODA was involved in found that about 50% of workers across the drug and alcohol, youth and mental health sectors were current smokers at the time. Staff at the time were also reporting almost universal smoking among service users, among their clients, and also reported being reluctant to ask about smoking and to provide treatment, with these points here being among the reasons that they would give for, having that reluctance. So that, people in drug treatment don't want to quit and can't quit, and it's too difficult to quit on top of drug and alcohol issues, and that talking about smoking might disrupt the therapeutic relationship. And as well as that, many workers reported at the time not having confidence to actually to ask about smoking and to provide advice and support. So I'm going to be talking about 4 activities that we have done collectively as a sector. The first 2 I'll talk about together because they're related projects: the Workplace Tobacco Management Project and the Under 10% Project. The third one is the We Can program, which is a program to provide free nicotine replacement therapy to service users of drug and alcohol services. And the fourth one that I'll also mention is the Tackling Nicotine Together research project, where 8 of our services were involved in a large national research project that was led by Billy Benevsky at the University of Newcastle. So first I'll talk about the Workplace Tobacco Management Project and the Under 10% Project. So the aims of these 2 projects was to strengthen tobacco management practices in health and community sector organisations that provide services to disadvantaged people. So it was actually projects that happened across the alcohol and other drug sector, and the youth and the mental health sectors in the ACT. So organisations from those 3 sectors came together and committed to strengthening tobacco management practices in their organisations. So the partners in the projects, they committed to, firstly, be a smoke-free workplace, that smokers won't smoke while on duty, and wouldn't take excess breaks and unauthorised breaks to smoke if they did want to continue. Workers and clients wouldn't smoke together, that they would provide support and information, and this included having free nicotine replacement therapy available to workers to quit if they wanted to, and or to reduce their smoking while at work, and also to communicate these policies through signage, etc., to workers and to service users. So some key resources that came out of this project was a template for workplace tobacco management policy that was adaptable to different service contexts, and also to, as I just said, to have NRT available free to help workers to manage tobacco consumption in the workplace. There was also signage and promotional materials available, and as well as access to subsidised training and resources for staff. So just to briefly mention the Tackling Nicotine Together project, this was a NHMRC funded research project which was led by researchers from the University of Newcastle, but also had a number of other collaborators, and it was conducted in 4 jurisdictions, which included the ACT. And it looked at the effectiveness of an organisational system change intervention at increasing smoking cessation in alcohol and other drug services. And in the ACT, there were 8 alcohol and other drug services involved. 4 of those were intervention sites and 4 were controls. The control sites, of course, did business as usual. And the 4 intervention sites had some key intervention activities, which included workers were provided with smoking cessation and NRT training, and then organisations were provided with nicotine replacement therapy that could be given to service users at no cost, along with smoking cessation advice and support. So all of these activities are really key, and having those in place has been, really fundamental to being able to advance our work in smoking cessation and supporting clients with smoking cessation. The last program I'm going to talk about is a program that ATODA manages, and it's called the We Can program, and the CAN stands for Communities Accessing All Types of Nicotine Replacement Therapy. And essentially the aim of this program was to reduce the disproportionate impact of smoking-related harms among people who are accessing specialist alcohol and other drug non-government organisations in the ACT. So importantly, this is only a program offered in the 9 non-government AOD services in the ACT, because the government service already had its own program in place. And the program facilitates access to all types of subsidised NRT, and it's complemented by smoking cessation advice. And I'll go into a little bit more detail in a moment. It's, as I said before, it's managed by ATODA, and it's implemented in partnership with the 9 NGOs, AOD NGOs, and with community pharmacies. So the rationale behind the program, so it's targeting people accessing AOD services who we know have high smoking rates, so 82% in the ACT, as I mentioned before. We know that many of these service users want to quit, and that they can do so with the right support. And we know also that there are better treatment outcomes, both for their alcohol and other drug treatment, but also for smoking cessation, if they are able to be supported to quit or reduce their smoking at the same time as dealing with alcohol and other drug treatment. We also know that, and I know that you all know this, that NRT is an effective tool to aid smoking cessation and reduction, and that better outcomes are provided when it's provided according to best practice, and best practice being a full course of NRT in combination and offered with other support. So some of the problems that we were having was that intermittent forms of NRT are largely unaffordable because they're not available on the PBS. And I know that recently we're about to have, I think, gum and lozenges listed on the PBS, but these are not available in combination with patches. And so it's very difficult for service users of AOD services to be able to afford access to combination therapy. There's also historically low levels of contact with general health services, which means that there is very low access to scripts for patches. And we also know that AOD workers have identified cost as a significant barrier. And as I mentioned before, that there is limited access to subsidised NRT through the government AOD service, but at the time of this program, when this program started, there wasn't NRT available through NGO AOD services. So how it works is that when a service user appears at an AOD service, they're screened and assessed for suitability to use NRT. That is, are they nicotine dependent and over 12 years old? If they are and they express an interest in wanting to use the program, they're offered the option of participating, and then they're provided with a voucher that has a unique identifier. And they also receive smoking cessation advice. They then are able to take this voucher, which is for $300, to a local community pharmacy. And what's happened is that each AOD service partners with a single community pharmacy, and a service user from that service can access that particular community pharmacy and present their voucher for NRT, for $300 worth of NRT. And the pharmacist then establishes an account for that service user, and then they're able to make multiple visits to the pharmacy to access NRT over however long they want to access it until the voucher runs out. And we did some extensive calculations, and $300 seems to last about the 8 weeks, but for some people it can extend a little longer. And so they also receive smoking cessation advice, particularly about the most appropriate NRT to use from the pharmacist, as well as having received that and continuing to receive that at the alcohol and other drug service that they've been accessing. Importantly, this program takes a settings-based approach. It's currently being offered at 8 specialist AOD NGOs, and it enables the delivery of best practice nicotine dependence treatment, so full courses in combination and with smoking cessation support from both AOD workers and from pharmacists. It's implemented as part of routine AOD treatment and support, so it's asked as part of the routine assessment that everybody gets when they access an AOD service. And so it leverages on the existing expertise of AOD workers and also on the organisational tobacco management policies. So services that participate in the WeCan program have to have already gone through the under 10% program, not necessarily as participants, but to commit to taking up those principles of having tobacco management policies in place. The WeCan program also leverages on existing smoking cessation training and resources available through ACT community pharmacies. So there's been a ACT-wide pharmacy program to specifically train and develop and provide resources to pharmacies to be able to deliver more effective smoking cessation support. So that's been excellent. We've been able to leverage off that program as well. So just in summary, I've talked about the Workplace Tobacco Management Project and the Under 10% Project and the WeCan program, as well as the TNT Research Project, and how these activities have allowed us to be able to provide service users who are largely disadvantaged and have high smoking rates. We've been able to provide smoking cessation screening, assessment and treatment, and embed those into routine AOD treatment. subsidised NRT for workers so that we can provide supportive workplaces, subsidised NRT for service users, and this is all types of NRT, full courses, and supported with further smoking cessation support from workers and pharmacists. We've also been able to provide training for staff with tools and resources to support smoking cessation. We've supported organisations to develop workplace tobacco management policies and also to have signage and promotional materials available. So this is being done, as I've mentioned before, as a collective across the sector activity. Of course, this is done within the broader context of what's happening in the ACT, which I described before, provides a supportive environment for us to do these various activities. So I'm now going to talk a little bit about some examples of some of the changes and impacts. So I should point out that, of course, we can't directly link the changes and impacts that we've noted through these programs only to these programs because of the supportive context that we've been working in, and you know, a whole lot of things could be linked to these changes and impacts. But I'll share a number of these findings with you. So back in 2011, we did a survey measuring some of the workplace tobacco management policies and attitudes towards that helped to develop some of the tobacco management activities. And the data that I'm talking about here is where we repeated some of those questions in the 2017 ACT ATOD Workforce Profile, which ATODA ran in 2017. And as I mentioned before, the data for this is unpublished at the moment, and so it's not for citation, but I wanted to share it as part of this webinar. So we found that in contrast to what was happening sort of 10 to 15 years ago, where hardly any services had tobacco management policies, we found that 100% of our services have a written workplace tobacco management policy, which is excellent, and all are either completely smoke-free or have a designated outdoor smoking area. We also found from this survey that 70% of staff are supportive or very supportive of their organisation's workplace tobacco management policy, which is also very positive. So when we asked we asked smokers about smoking, and that workers agreed or strongly agreed, so about 76%, that all service users should be asked about their smoking status, so that's excellent, and that service users should be encouraged to quit smoking, around 59%. And we found that around 67% ask every service user if they're a smoker, and if the service user says that they're a smoker, around 59% offer them some kind of smoking cessation advice. And this is, again, higher than what we were finding in 2011. And the reason I'm not directly comparing it to 2011, I'm just making sort of a general statement about it, is because the data in 2011 related to the AOD, youth and mental health sectors, not just the AOD sector. So it's not directly comparable, but it does give us some idea. We've found that of workers who have client contact, direct client contact, that 66% of them have received some form of tobacco training, which is pretty good, although we've got a third who still require some tobacco training, so there's still room for improvement. About 69% said that they feel extremely or very much that they're confident in talking to service users about their smoking or quitting, and that 64% felt that their own smoking status did not affect how confident they were in talking to others about their smoking or quitting. Some attitudinal statements. So only small proportions, 12% and 6% respectively, agreed or strongly agreed that you could only treat one issue at a time. So most workers were agreeing that you could deal with smoking at the same time as AOD issues, and that only a small minority said it would be impossible to give up two dependencies at once. So most thought that you could tackle everything at the same time, which was great, and again, different to what was found in 2011. But about a third felt that service users don't want to stop smoking. So that's still quite high, and we need to do some work there, obviously. So compared to 50% in 2011, which was the smoking status of staff then who identified themselves as being current smokers, we found that, so 17%, so what's that, 26% were either current daily or occasional smokers. So that's halved, which is great. The Service User Satisfaction Outcomes Survey, which is the survey that we used where we found that 82% were smokers. We also asked a question in that survey about how their smoking status changed on use of the service. So since first entering or starting to use the service, 16% of service users said that they had quit smoking completely, and 41% said that they smoke less now than when they first entered or started using the service. So around 57% were either quitting completely or smoking less by virtue of using their services. Probably other things as well, but that's what they reported. So some information from the We Can program. This comes from the operational data of the We Can program, where we provided vouchers for $300 to service users. So we had a pilot program of 20 months where we collected data intensively, and this is where this data comes from. So that is from July 2015 to February 2017, so about 20-month period. And we distributed 325 vouchers during that time, about 60% to men, 40% to women, and the average age being 34 years, and 14.5% were to Aboriginal or Torres Strait Islander service users. And we've found that the program has really improved access to sufficient NRT and smoking cessation support to make high quality attempts to quit or reduce smoking. We haven't, through our data, been able to actually track people to see whether this has actually resulted in successful quit attempts, but we have found that people are at least able to make quality quit attempts through this program. 82% of the vouchers that people received were presented at a pharmacy, so it represents about 82% of people making potential quit attempts. And at least 28% at least 28 of the 325 people made more than one quit attempt, so they received more than one voucher. And in one case, somebody received 4 vouchers, so we're able to really have a go at it. And people were able to access sufficient NRT to make quality quit attempts. So on average, just over 2.5 times per voucher was the number of times people visited the pharmacy. And 40% of the vouchers were completely or almost completely expended for a full course of NRT, and 81% of the vouchers were used to purchase a combination of patches and intermittent forms of NRT. So people were using the vouchers sort of in the way that we had intended them to be used. 100% of participating service users also received smoking cessation support from an AOD worker or a community pharmacist. And we have received, through the evaluation, really positive feedback from service users, AOD workers and pharmacies, and that the program is working effectively to support quit attempts. As I said, we haven't been able to measure the actual successful quit attempts, but we know that we're at least supporting these to happen. So just to make some concluding remarks, these programs were really around trying to improve equity in nicotine dependence treatment. We strongly at ATODA believe that policy levers are no longer sufficient to affect the smoking behaviour of disadvantaged people who are still disadvantaged people who are still smoking, and that the last 10% of people smoking in the ACT, that a large proportion of these people are disadvantaged, and that we really need to now turn our attention less from regulation and more towards actually providing targeted access and targeted programs that provide high quality nicotine dependence treatment. And to do this, we believe that we need well-resourced, targeted settings-based interventions, such as those delivered through the AOD services that I've been talking about, and that take advantage of the existing infrastructure and expertise in the ATOD sector. So we would advocate for ongoing strategic and coordinated programs across specialist AOD services, and also across other health and community services in the ACT and nationally, of course. And that this happened through strategic and coordinated programs of tobacco management and smoking cessation activities that can lead to improvements in the delivery of nicotine dependence treatment alongside specialist AOD treatment, have supportive organisational policy wrapped around those activities, improve equity of access to nicotine dependence treatment, and consequently have improved smoking-related health outcomes for AOD service users who smoke. And just finally, these are some of the references that I referred to, and some of these are available on our website and can be found there. Any questions? Now, hang on, I'll just stop sharing.
Thank you so very much, Anke. That's hartelijk bedankt. Thank you very much in Dutch. Has anybody got any questions? You can either ask them by speaking up, or chat with a question. I think Amy.
Oh, hi, Amy.
Dan, Helen. Perhaps we can start with Amy. First in, best dressed. Amy, can you turn on your speaker?
Can you hear me?
I can, Amy. Hi, how are you going?
Hello, I'm well. How are you? I didn't actually have a question, so I don't know why I've been asked first.
All right.
Well, no, I can quickly think of one though. So Anke, in your with your policy hat, do you know if they're going to give us any more money in ACT Health for disadvantaged populations, specifically those of the mental health variety?
Oh, I don't know, Amy, but I hope soon, yes. I mean, it's not up to us. We've been advocating for a long time, and we've been, all of the, the budget submissions that we put in, we've always got NRT in there, and we've tried several times to not only have it for AOD, but also to have it for, wider disadvantaged communities through things like mental health services, and but no success yet.
We'll keep trying. We'll keep trying.
Keep trying. You too.
Dan, do you have a question? From Dan, thank you. A lot of overlays with trying to read the rest of it. Dan. So thank you.
A lot of overlays with the local experience in Alice Springs, financial access barriers to smoking. Exactly, yeah, there's lots of financial barriers to accessing the services. The programs seem to be making some good ground. Yes, well, Dan, I think we have been making good ground, and we're oh, okay, all right, no worries. We have been making good ground, we think, and certainly, as I said, we don't know how we're actually impacting on smoking rates, but we do know that we're impacting on access to best practice smoking cessation treatments, which is great, and having them embedded into AOD treatment as part of a comprehensive and standard practice has been really, really good. So Yeah.
Helene. Yes, a question? Perhaps not. Can I ask a question? Just which has been burning for me for the last half an hour or so. The program is heavily NRT focused.
Yes, it is.
And given we're talking about best practice,
yes,
and evidence-based best practice,
yes.
I was curious to ask why you haven't included in the project generally, globally, more incorporation of other pharmacotherapies, evidently like varenicline. I must declare I have no conflicts of interest with this question at all. I don't work for companies of any sort.
No, look, it's largely just at the moment historically based. It's just because the program that we applied for, that's been going for a while, we just applied for NRT funding, and it's just historical at the moment. And so until we can get this properly funded in an ongoing sustainable kind of way, we would then look at expanding it to other, as you say, best practice like stop smoking medications, which are very effective too, exactly, and suit different people better as well. And more so in some cases, that's right, exactly, for some people more so, exactly.
Does it require a GP, obviously, to prescribe? That's always a stumbling block with this group of patients or clients. But we've been working on this for some time ourselves and looking at having sympathetic, medical practitioners or groups, medical practices that will be supportive and knowledgeable on this, because sometimes there is a bit of misinformation about in this particular client group. So informing better the GPs in the area, it may help hugely get this underway as a prescription, because everybody in this particular group entirely entitled to subsidised varenicline for more than 6 months. So I'm thinking, go for it without waiting for funding.
Yeah, look, I agree. But part of it is our internal capacity. So we, as an organisation, don't have the capacity to expand to do any other kind of work at the moment. So we're just waiting to get some more money in this area to be able to look at some other issues. And certainly that would be one of the other areas that we would want to expand in, because, as you say, it's very helpful for many people.
Perhaps Lynn Boucher. Lynn, do you have a question, Lynn? Unmute if you do.
I see there's a written one here from 1004 Norton. I don't know who that is, but so you mentioned that the WeCan program uses a settings-based approach. Why was that chosen, and are there other approaches that may apply better elsewhere? Well, we specifically used a setting-based approach because we wanted to, in this case, because we wanted to leverage off the expertise of the alcohol and other drug services. And so it's also very, oh, hello, David. It's David McDonald who asked the question. I think that in this case, settings-based approach really makes sense because it enables, because we know that high proportions of people accessing alcohol and other drug services it's one of their only contacts with the health system. And so to have smoking cessation support offered within a setting is really helpful to access this population. And I think that because we're working with existing expertise where drug and alcohol workers are used to, many have been trained in smoking cessation, and many of them have, for instance, motivational interviewing skills that they've used with both their alcohol and other drug treatment and tobacco treatment, that we're able to leverage of those sort of things in this kind of setting. I think that it could be possibly expanded to other settings where training is provided to workers to be able to support smoking cessation, but it may not be appropriate for all settings. Hope that answers the question, David.
I did see Lynn Boucher there for a minute.
Yes, I saw someone else, yeah.
Very, evidently very warm Queensland where she is. Is anybody else logged on for a question? Was that a question from you, Lynn? Possibly not, Lynn. Well, if there aren't any more questions, Kevin, I think we might call it a day and suggest that those who are listening in and those who've got experience with anything related to these topics, drug and alcohol, mental health in particular, and any, of course, smoking cessation expertise or research or work that you've been doing, we would be very pleased to have you present, as Anke did, your work so that, again, we can learn from their experiences, each other's experiences. And this, of course, is a group, the APSAD group now, the Special Interest Group for Smoking Cessation and Tobacco Treatment is Australasian, which means New Zealand. Anybody listening in and logging on, they will have the ability, I believe, Kevin, to see this presentation as he...
Yes, we have recorded it.
So this has been recorded, so your colleagues, friends can log in and have a look. You don't necessarily need to be a member to look at these presentations. So you can invite your colleagues anywhere to have a look. So with regard to the next presentation coming up in February, we've had a little bit of a glitch with the presenter who is actually having to support his PhD thesis, that is, he's got to speak to it on the very day that he agreed to speak for us. So we said, well, you know, you've got your priorities. No, obviously we forgive him, and we'd be very happy to hear him speaking next time. And that's Rodrigo from Auckland with a very interesting thesis. And so hopefully very shortly he'll be presenting. We're also hoping to have as an extra additional presentation during the next couple of months, we will be hearing from, and having here in Australia, we'll be having Robert West, the very famous Professor Robert West, Editor-in-Chief, I'm sure you know, of Addiction, the journal, and a very interesting person to have here, perhaps to discuss some nuances about addiction generally. And it will be great to hear from Robert, and we can put some questions to him about some pertinent issues that are going on in the UK right now. So that'll be Robert coming in, Kevin, in April.
I think Lynn Boucher's put her hand up. I tried to promote her so that she could speak. Can you ask your question, Lynn? Not working. The sound's not...
Maybe too hot in downtown Brisbane today. It looks awfully...
Or maybe type it. Maybe, Lynn, you could type in.
Perhaps type.
I've got...
as I said, if the technology doesn't work, it's usually, we hope, not our end of it. And publishing, are you publishing on this, Anke?
Yes, look, we're hoping to. We're hoping to do publish a comprehensive report that provides basically all of the different programs that we've been doing. A little bit there, we just want to bring it all together. So
I think if you could point out when it is published to our group, it would be wonderful, because that information is very pertinent to be disseminated, as I said, nationally and internationally. Thank you very much. Kevin.
That's all, I think.
Thank you so much again, Kevin.
Mm-hmm.
We can see it's hot where you are because of your Hawaiian shirt. Yes, thank you. So goodbye, everybody, and we will see you next month. We will alert you as to what the topic will be, because we've only just heard that Rodrigo could not do it on the day that we had set. So we'll let you know as soon as we possibly can what will be happening. So thank you, everybody, and goodbye.
Thank you.
Anke, so very much.
Bye-bye.
Lovely. Thank you.